you for those of you who came to the Triangle Global Health Consortium Conference and came to see me again. It's a very different talk, obviously. I talked about malaria about a month ago. So I'm Laura HOEMEKE. I work with IntraHealth International. How many of you have heard of IntraHealth International? That's great. I do have a few of our annual reports. I've worked with IntraHealth since 2003. So I actually started in Senegal as the regional director for basically Francophone West and Central Africa, and then worked in Rwanda for 5 years, heading up the decentralization and health project that was funded by USAID. And then I've been here in our Chapel Hill office for 7 years, which is hard to believe. I'd like to say back in Chapel Hill, but I actually never lived here before. So I've had some cultural adjustment, I feel like, moving here as well as to other countries. And I'm thrilled, and I wanted to thank you both, and Caitlin especially, for inviting me to speak today. How many of you know what advocacy is? Advocacy. How would you define advocacy? Just a guess. There's no wrong answer. Well, there might be, but when we say we go out and advocate for something, like we want to advocate for reproductive health.
Promoting or standing up for.
Promoting, standing up for, that's a good definition.
Presenting evidence that supports something.
Presenting evidence, so evidence-based advocacy.
Trying to garner support.
Trying to garner support? Yeah, great. More?
Attempting to influence a decision that can either be political or social.
Yeah, so attempt to influence a decision, and that's really good. So I put on this slide the way we define advocacy at IntraHealth. I'm Director of Communications and Advocacy, and IntraHealth is unique in that we have communications and advocacy in the same department, but I think it actually makes both of our communications and our advocacy stronger. Because our communications, if you look at our website or even our annual report, is really focused on our mission and mission-driven. So again, you got all the right answers. You all get gold stars. It really is evidence-based, because some people think advocacy is more like a campaign, and that can be part of it. A clever campaign like the Ice Bucket Challenge a few years ago or something, but really to be effective, advocacy has to be evidence-based. And it has to be strategic too. So we have advocacy strategies just like we have strategies for a family planning project or a malaria project, et cetera. So what is the strategy? And an advocacy strategy is really what are we trying to change to foster an enabling policy environment and increase resources? So I think you touched on both of those. And sometimes it's garnering attention, and sometimes it's actually garnering resources where there isn't enough funding globally for a specific issue like reproductive health. And again, it goes beyond educating and raising awareness, although that can be an important part of advocacy. That it's really about changing the behaviors of decision makers and politicians and those who actually have control, for example, over a budget or over policies. Again, calling attention to resources needed to further the achievement of our mission at IntraHealth. And we focus really on health workers and the health systems in which they work, which is fairly broad. And again, IntraHealth, our advocacy is informed by evidence that we generate through our ongoing projects and work. Our advocacy can also be informed by other evidence, and we constantly track what's happening globally. Before I move on to reproductive health, at IntraHealth, we kind of divide our advocacy into 3 levels. So there's global level. So we are in official relations with the World Health Organization and attend the annual meeting, which is called the World Health Assembly, every May, and work a lot with the UN agencies during that and with other country governments. It is very bureaucratic, and it's a week of, or 10 days actually, just of back-to-back meetings and sitting in sessions for hours, but at the same time, and I've been able to go 5 times now, being in official relations with WHO, we also get to make official statements on resolutions. So we study all the resolutions before the assembly, and then again, want to have an evidence-based statement, and they actually listen to you, and the resolution can change, and it's really a kick when you see the final one and you realize some of your language might have been incorporated in it. I don't get nervous usually when I'm speaking, but I remember that first time at World Health Assembly, I had my paper, and all of a sudden I look up, and it's all the countries in the world. And it was like, you know, I kind of had to like put it somewhere so I wouldn't get nervous. But so that's kind of global level, looking at globally, how can we help influence the agenda? Whether it's reproductive health, non-communicable diseases has been high on the agenda for the last couple of years, especially emergency assistance. I think you all know WHO got in trouble for mismanagement, really, of the Ebola response, so a lot of things have changed. There's a brand new Director General now, Dr. Tedros from Ethiopia, so he looks like he's going to be bringing in some really good leadership. He's already brought in more female directors than any other Director General of WHO, so we're all excited about that, and they look like great women. We also advocate with the US government and other donors. So IntraHealth actually does lobby. And sometimes people think that's a bad word. It's not, and we just started doing it a couple of years ago. But nonprofits can lobby, and we're allowed to, as long as we're very careful about the money we use for lobbying, and lobbying not with money that we get from the US government, but from other sources. And an example of that, maybe we hold congressional briefings in which we educate Congress about specific issues. We do, our team based in DC especially, and small team, 3 of them, you know, just go to congressional offices and talk to their staff and talk about what's coming up. And we, for global health in general, I hope most of you know that there is bipartisan support for global health broadly. It gets trickier when you get into things like reproductive health. But if you could, what I'm going to talk about today a little bit is how can we counter some of those arguments that people have about topics they might consider more sensitive, like reproductive health. And then our third level of advocacy is really at the country level. So IntraHealth has worked in 100 countries around the world, and almost every country in which we've worked, we have some advocacy component to our project. And it was funny, we've really developed this over the past 5 years because we were doing advocacy, but people were saying we weren't doing it. So we did a survey several years ago, actually, when advocacy was added to our department of all staff, and many of the country staff, when we said, do you do advocacy? Do you engage in advocacy? They said no. And then intentionally, a few questions later, we said, have you ever worked on changing a policy or informing a policy to make the policy environment more enabling for maternal health or for child survival? And they all said yes. So we understood that our problem wasn't that we weren't doing advocacy, it was that people didn't realize they were doing advocacy. So we've worked a lot over the last few years in really internalizing it so that people, and partially because we really see the future nonprofit having to do advocacy. And there have been a lot of studies that have been done around this, that our role is changing as capacity is built in the countries in which we work. But there's still technical assistance needed, especially in the area of advocacy and policy analysis. So again, it's really important for us that we develop that it's seen as an expertise and not something just that anyone can do without knowing exactly what it is. So we take it seriously. So reproductive health, there are a lot of naysayers. The hardest country I worked in which I supported reproductive health was Benin in West Africa. I worked for the USAID for 4 years, and we had family planning programs. And guess who was against reproductive health in Benin? Pardon?
Women? I don't know.
Well, women, you're right. Women, men, everyone. Benin is a very Catholic country, but it's also, in Benin they joke that it's 10% Muslim, 90% Catholic, and 100% voodoo. So Benin is actually the birthplace of the voodoo religion. And voodoo we think about in Haiti came from Benin, which is really fascinating. So we had we had all kinds of barriers that we were dealing with and thinking about, these, what they called religious objections. God's will was that women and couples have as many children as physically possible before they die. They also actually had a brochure that they put out, and I was looking for my copy. They said reproductive health programs are equivalent to castration of men, which was, again, the strongest. And then they also, the priests were giving homilies or sermons about it on Sunday. So it was really hard to have programs that we knew, and surveys showed that women did want to at least space the birth or not have a child every 12 months. But we had the strong opposition from the Catholic Church, so we really had to work closely with them, and again, with other religious leaders. In Senegal, it's the imams in the Muslim church that we've worked very closely with, and sort of showing that you can save lives, and God, whatever God you believe in, is not against. God, we don't think, wants babies to die, or mothers to die in childbirth, so you really have to tailor it, to those religious objections. There are a lot of cultures that are still very pro-natalist. And when I worked in Rwanda, we started with a situation. I moved there in 2005, so it was 10 years after the genocide, 11. The country was still rebuilding its health system. Before the genocide, so before 1994, the country had one of the highest rates of the use of modern contraception in the region. And guess what happens when something as horrific as a war or genocide happens?
Right.
It went almost to zero. So it went from 13%, which again is not that high, but it was high at the time, to zero. And the project, and then it was 4% in 2005. And the goal of our project was to get the voluntary use of modern contraception to 20% in 5 years. And we kind of thought this is possible. It actually was 47% at the end of the project. And there's that success story has been documented a lot. It's one of my professional achievements, of which I'm very proud. Because, we worked together with a lot of different partners. We worked very closely with the Catholic Church, which is also influential in Rwanda. Worked with mayors. We did a training of mayors in family planning, and everyone said, oh, let's just do some slides. And we said, no, this has to be a hands-on training. So we passed around an IUD. We passed around female condoms, and they opened them, and they touched them, and it was very tactile, because we really felt like in order for the mayors to have an influence, and they do in Rwanda, they needed to touch it. They needed to understand. And one of my favorite quotes, and I actually wrote a blog about it recently, was there was just IUD. They were saying, but it's so tiny. They thought it was like some massive thing that the woman had to somehow insert. And so again, just using really hands-on things. We worked with journalists. We got the project I was managing was funded by the U.S. government. We also got funding from the Hewlett Foundation and Packard to do a lot of really creative things that were not included in the U.S. government funding. So it was training mayors, training journalists. And again, not training journalists in a classroom, but going out to health centers with them and saying, okay, everyone has to come back with a story today. And then having prizes for the best stories. So again, just very creative ways and a lot of it was advocacy, and it was creating that enabling policy environment. When we started the project, we were told that the president of Rwanda will never talk about family planning publicly. And if you know the history of Rwanda a little bit, there are two major ethnic groups. They are Rwandan, but the reality is there are two self-identified ethnic groups, Tutsis, but so the president won't talk about it because he doesn't want population to go down, or population growth to go down, and especially for his ethnic group. And he's afraid if he starts talking about it, certain people will listen to him and others won't. If you think about that, and yet there's been speculation. There's a great article by a demographer named John May, if you're interested, that the dense population of Rwanda could have been one of the contributing factors to the war and genocide. So, you know, we had this pressure. It is one of the most densely populated countries in Africa still. So there was a desire. So we had a technical working group for family planning. We spent like 6 months writing a memo to the president's office to ask him to talk about family planning on the radio. And worked on this memo, met every week, nothing happened. Finally, I got a call from the Minister of Health at like 10 p.m. one night, and he said, we're having our government retreat next week, and the Minister of Finance and I want to do a presentation about family planning. Can you help us with it? So it almost felt like it was like a secretive meeting, like in the dark of the night, where I went, and this other guy, there were 2 other people there, and we really pulled in all of the economic arguments, which I'll show you in a few minutes, to show that it wasn't just about saving women's lives and babies' lives, and we should all care about that, of course, but that also showing that economic growth is really related to widespread availability and use of family planning and people being able to control their fertility. And we have the slides, I still have them, and the week after the government retreat, the President Kagame came out and made a public speech about family planning, and then he didn't stop talking about it. It was like every single health meeting we had, family planning would come out, and it was like, it could be a meeting about malaria, and he'd talk about family planning, and it wouldn't work in every country, but in a country like Rwanda, which does have an authoritarian government, people listen to the president. I don't think it would work in this country as well, if that were an issue. No comment, but they listened, and the numbers started going up. So all of these advocacy things were happening, and while we were also working on service delivery and making sure enough health workers were trained, and they were trained in the right methods and the right method mix, and that contraceptive supplies were available. But it was a great story to be a part of. And again, I have an old presentation that I think I did in 2006, when they said it just won't work in Rwanda. And then after it worked in Rwanda, now when I go to West Africa, they say, like Senegal, they say, well, that's Rwanda, it won't work in Senegal. So you do have to kind of tailor it to the reality of the country. And then just a common argument you hear from people who don't want change, and I heard it in Tanzania recently, is, you know, women might say that they want to limit their births or space them, but they don't really want to use contraception. They don't really. And a lot of the focus, if you look at, you all know about the Guttmacher Institute, which does a lot of great research on abortion and family planning and reproductive health in general. Their studies for the last couple of years, and they do a global kind of contraceptive use study, they actually showed that one of the major reasons the women who say they want to use it and don't use it, don't actually use it, is because they're afraid of the side effects. It's not, access to a method doesn't come up very high. Sometimes religion is in there somewhere, but one of the highest ones is always afraid of side effects, which you would think, first of all side effects are temporary, and most of them, the benefits far outweigh any risk. And yet, so it definitely shows that there's just a problem with education and communication. Yes,
In the side effects, is infertility included in that, or is that an entirely separate concern?
That is a concern, and people are afraid that using contraception will make them sterile, as they say. So infertility is one of the major ones, and there is a breakdown, and I didn't put it in here, but I'm happy to share that report too. I think it's fascinating, because I think, again, we have to use evidence to tailor our programs, because if not, you can focus on access and have contraceptives everywhere, and hand somebody one, and they still won't want to use it. So we have to figure out really what are the barriers, and why are they not using it. So again, reproductive health is really an investment, and healthy populations, general human development, but also social and economic growth. So it's an investment in health, women's empowerment, and economic growth. And when you look at those arguments that what I call the naysayers use, these are the arguments we can use to get them to change their mind, and we have successfully. The current administration in the US is a challenge. I'm not going to say that we have all the answers, but we're working on it. We're not giving up. The great thing is that there are so many governments the countries in which we work, which are investing themselves in family planning and reproductive health, because the governments see the benefits. So when US government funding goes away, there's a way to find some other funding. So why do I have this up there? What is this a picture of? Birth control.
The sign of the astrological sign of the woman within.
Uh-huh. So this was, let me make sure I got the date right. In 1960 is when the FDA approved the oral contraceptive or the birth control pill. And historically, until then, there really wasn't an effective, and I'll show you the effectiveness of different methods, there wasn't an effective, relatively easy to use method. And once it was approved in the US, globally, it spread very rapidly. So prior to that, people were using, what we call coitus interruptus, otherwise called withdrawal, or pull it out. There were attempted abortions, which again is a horrible thing, and a lot of women died. Infanticide, if people really didn't want to have a baby and didn't know what to do, or other more indigenous birth control devices like herbs and things like that, which are inserted into the vagina or uterus, which again have not been historically effective. But again, the pill, and then once the pill was, and there were condoms, but the condoms were not as effective as they are now. And I think a lot of you know that, like condoms, they've been around for hundreds of years. They were literally made of like sheepskin and not very effective. So once we had modern, what we call modern contraception, the effectiveness was so much greater that women and couples, well, you want it to be couples, but women especially decided to use them. And then it took a few years for that diffusion of innovation, but not that many. So again, it was approved, the pill was approved in 1960, and this is Time magazine article, cover from 1967. That was really an article about the contraceptive revolution and how it changed people's lives. And just as an example of that, you can really track it when you look at fertility rates around the world. So I think I have a laser, but I don't need it, I think. If you look starting around 1960, so we're like here, is when in higher income countries, so that's richer countries, including the US, in Africa, in Latin America, look at that drop in Latin America. In Asia, and even around the world, which is this purple line, once effective modern contraception was available, and other things were contributing too. Countries were changing, urbanization was happening, people who used to say we need a lot of children to be able to work the farms, that was changing for some people. Another thing that happened at the same time, and if you like this kind of stuff, does anyone know Hans Rosling? He has he passed away unfortunately this year. He's one of my heroes. I have a geek crush on him, I like to say, but I've seen him speak at a few conferences, and he has a website called gapminder.org that has all kinds of graphs like this, and graphs that you yourself can play with and move around and look at. And one of his points, which I want to make too, is really important, is around the time that fertility rates started to drop, child health improved drastically. So, which happened first? It's hard to tell, but when people knew that their children would live to a certain age, maybe they were okay with having fewer children. Or maybe child mortality also dropped because people were spacing out births and having fewer children. But again, there's a definite link there and a reason to continue to invest in child survival. Any other questions about this? you can see there's a little uptake here, which is kind of interesting. I mean, we know now, and especially in some European countries, governments are actually encouraging, putting incentives in place to encourage couples to have more children.
What's replacement fertility, 2.2?
Mm-hmm. Yeah, good question, thank you. So yeah, if you look here, it's around replacement, yeah. So Africa is still the most challenging place as far as the use of modern contraception. IntraHealth works a lot, especially in West Africa, which had the lowest rates in the world, and they've gone up significantly in the last 5 years, and I could do a whole different presentation on that, which I'm happy to do, but again, if you're interested, you can look on our website. There's been a lot of great work done in West Africa, and in some ways applying some of what worked in Rwanda, which is working with mayors, working with religious leaders, working with women's leaders. I mean, I think, you know, reproductive health is really a female women's empowerment issue. So in cultures where women don't have the power, whether it's to talk to their partner or spouse about children, or don't have the right to own land, or don't have the right to keep their money if they're working, I mean, that all is a reason for not, if a woman's value is associated more closely with the number of children she has than anything else, guess what happens? So again, I assume everyone's familiar with the Sustainable Development Goals. So I just wanted to point this out very quickly. There are 17 of them, which is a lot. There are only 5 Millennium Development Goals. The interesting thing, though, is that reproductive health was not in the Millennium Development Goals. We had maternal and child survival and goals around that, but not reproductive health. And now it's actually part of SDG 3, which is really the goal focused on health. But again, family planning, reproductive health also obviously has an impact on eradicating poverty, by supporting economic growth, and even at the family level, improving the economic or financial situation of families. 3 is really all about health and includes the goal of universal health coverage for essential life-saving services, including reproductive health, which again wasn't in the goals before. And then it really contributes, well, goal 17 is really strategic partnerships, which is a little vague, but you need partnerships. And really all of the SDGs, if you look at the 17, by contributing to economic development. Another one, which it should be up there, 5 is about gender empowerment. And again, if you listed them all out, you could have an argument for each one. Question?
I have a question. So with respect to these goals, certain countries have empowered women to not have children as a way to take control of their professional life. Like in Japan, you know, there's a decreasing rates of women having children due to the thing I just mentioned. Do you think that is empowerment? You know, by basically giving the option like have kids or don't have kids, but the way for you to succeed is not have kids. Do you think it would be optimal to both include an option to have kids but also feel financially stable as well?
Absolutely.
And if so, like how do you consider the alternative, like in the circumstance I mentioned, like almost like a failure?
Yeah, in fact, China is a good example because they tried a one-child policy for how many years that led to a number of problems, including infanticide and really femicide, because a lot of girl babies were killed, led to, as I think you all know, a whole generation of boys, really, and with very few women of their peer group and age. And when I was working in Rwanda, the parliament actually wanted to pass a similar law. And we all kind of jumped up and down and said, no, please don't do this, it won't work. And then they said, okay, how about instead of 1 child, 2? And they had a law written that said, if only 2 children, and we tried to explain this is not going to work. I mean, every contraceptive has failure rates. Even if your goal is 2, there are other ways to move toward that. And then they finally said, how about 3? Because that way, if there's a mistake, we're going to let them have 3. And they wanted to punish people who had more than 3 children. So think about how regressive that is. So basically, poor people who, and the president himself, we pointed out, had 4 children. So it's like, but so we do not, I mean, the whole, and that's a really good question. We really believe in voluntary use of modern contraception and desired birth. That every birth is desired, hopefully by a woman and man or the 2 parents, but that women especially are empowered to decide how many children they can have. And that's why I said there are a lot of countries, especially in Europe, where they're putting in place more pro-natalist policies. Like, I'm very jealous, a friend of mine who's Icelandic had twins, and then she got 9 months paid leave. I know. So
She probably gets daycare too.
and daycare is included. I mean, this country, the U.S., is not very progressive as far as pro-natalist and pro-parent and pro-women policies in that way. But a lot of the Scandinavian countries are for sure. And yes, so to answer your question more directly, women shouldn't have to choose. But unfortunately, the case is in a lot of countries, and the U.S. to some extent, at some point you do have to choose. And it's not easy. And we do, IntraHealth does a lot of studies around gender discrimination around the world too, and looking at, especially health workers, how their careers are affected if they're women, and they choose to have children, and can they keep their job, and country after country shows that they kind of hit a plateau and aren't promoted further, especially when they have children, or women aren't hired for certain jobs because if they're young, it's assumed that they will take maternity leave and have children. I'm proud of the fact that IntraHealth has a good maternity leave program, not parental leave, so that both women and men can take a full 3 months of leave, which again is not your 9 months of Iceland, but it's something. So again, family planning, a group did a study, let me make sure I cite the right name of the group, that showed that they studied a lot of different investments in global health, and they found that family planning is what they call a best buy, and it's in the Copenhagen Consensus Report. But again, studying these different interventions, as we call them, and how much they cost, and family planning was one of the top 10. So for every $25, it costs on average $25 per woman per year to ensure that she has access to contraception. And the return on that, on every dollar, not on the 25, on every single dollar, is about $150 to society. So, and that's on improved health. So if you think about people are less sick, they may need less health care, they're not missing work, they're not dying. There's an environmental impact and a social economic impact. So again, this argument works really well with policymakers. If you're going into a country like Senegal and saying, look at this, it's hard for people to understand because you're not going to see the benefits tomorrow. But any public health intervention that's mostly based on prevention is a long-term investment. But again, it does work, and I think, and that's where people like to look at Rwanda because it's doing pretty well economically, and they say, well, if they can do it, and then we can too. So again, social growth and development. The global development community, especially the healthies we call them, there's the healthies, the economists, the techies, but the healthies in the past often have not wanted to talk about money because it seems kind of like we're not caring, we're not humanitarians, so we need to talk more about saving babies and women's lives. So there has been some squeamishness in talking about the economic impact of family planning. But at the same time, we know that the fiscal benefits to countries who've invested in it, and again, more and more countries, poor countries, are investing their own money to make sure that people have access to contraception, that they're enormous. And so the more evidence we have and the more data, I think more countries will want to invest. And again, that's why I didn't want to focus today just on advocating with the US government, because it doesn't have to be just the US government. And again, as more people make the transition from large families and short lives, children die early, to smaller families and longer lives. You think about it, health, family size, and prosperity are all intertwined, and they all improve. Once a couple or a woman has the number of children they want, has healthy spacing of births, we're really, really careful, like I said, it's voluntary use, no coercion, no, any policy we see that we think involves coercion, or there was a huge problem in Peru, like back in the 70s, with a US government-funded project that had quotas for how many women a health worker could get to use contraception. And it was deemed to actually, it really caused huge problems in the US, where a lot of people in Congress didn't want to fund family planning anymore because they said we're like forcing women to not have babies. So the government is really careful about that, and there are all kinds of amendments around that, and even a family planning project like the one I ran in Rwanda, you have an inspection visit come out and visit your sites and talk to health workers and make sure there's no coercion going on, it's all voluntary, including with vasectomy, which is an interesting one. And then countries can also benefit from what we call the demographic dividend. Do people know what that is? Does anyone want to hazard a guess? So the demographic dividend, actually, and I apologize, I should have put a graphic showing it, but it happens when, if you think about it, you start with a country like with high fertility. Like Niger still has between 7 and 8 births per woman. And that country then, so then you have an age pyramid that looks like this, right? Because you've got a lot of babies and fewer older people. And once women start to use contraception in couples, then fertility goes down. So that bottom part of the age pyramid actually gets a little smaller, and that bulge that was at the bottom over time moves up through the age pyramid. Does that make sense? Yeah. So then when that bulge is of working age and productive age, they can actually help an economy grow if they have access to education and jobs. So, and again, I apologize for not having a visual, because I think that is an important concept to understand, and a lot of people, including policymakers, don't understand it. Because, again, using Rwanda, well, we thought having more babies meant economic growth. Like, that's what they asked in a parliamentary session. Or they assume that the demographic dividend happens automatically when contraceptive use goes up. But unless a country has, like I said, the education system in place and job opportunities, it doesn't matter. You could have a lot of unemployed 20 and 30 somethings that would not be contributing to economic growth. So it has to be this multi-sectoral, working with various ministries on different policies and programs. And I also wanted to include something about climate change, which is tricky, because again, if you talk about it to poorer countries or low-income countries, they say, well, we're not really the ones contributing most to climate change. And I was a little embarrassed when I was in Rwanda and somebody came out from Hewlett Foundation and that was his focus. And he talked to the Minister of Health, and the Minister of Health said, look at your own country. Look at industrialized countries that are pumping things into the air. However, studies do show that the biggest way to reduce climate change is to have fewer children. I thought it was fascinating that that was like number one, and there were some others that they found, including having fewer children, living without a car, avoiding airplane travel. Well, guilty, like eating a vegetarian diet, guilty. But again, as more people, if you look at it globally and not pointing to an individual family in Rwanda, as more people make the transition, on average, to smaller families, again, you have these three elements that are intertwined that will happen. And the woman, one of the researchers, was interviewed on NPR, and she said, I knew this was a sensitive topic to bring up, Certainly it's not my place as a scientist to dictate choices for other people, but I do think it's my place to do the analysis and report it fairly. And that's actually a pretty new study. It was July 2017 that she was interviewed on NPR. So I think there are ways to handle this kind of sensitive topic differently. I think it really actually needs to be discussed more at the global level than, again, with poor countries who can argue that they're not the ones contributing the most damage to our climate. Any questions about that? So again, just a reminder, not all methods are the same. So the average woman of reproductive age who's sexually active, if she's not using any method of birth control or modern contraception, on average, 15% of women will get pregnant every year. When you go to methods like condoms or withdrawal, it gets, oh, sorry, so 15% will not get pregnant. Whereas condoms and withdrawal, 70 to 80%. So, and again, this is assuming there are no infertility problems, et cetera. So they looked at all of this. Pills and injectables are much more effective. And then what we call permanent methods, or long-term and permanent methods, are more than 99% effective. So it really does matter, and especially the family planning community is really focusing on this last category right now, which are LARCs, we love our acronyms, long-acting reversible contraception, like an implant that can last for 5 to 7 years, or an IUD, which is very effective, 100% reversible, pull it out, pull that big thing out, or sterilization and vasectomy. And in poor countries, actually, female sterilization's been around forever, and there was a big scandal in India. It was in the New York Times a few months ago that women were like being sterilized without even knowing they were, and it was like the #1 choice, the #1 method of contraception used, and it would happen when a woman went in to deliver, and then they would do it at the same time. So again, you have to be careful about that. Countries where people said men will never want vasectomy are actually numbers are starting to go up, including Rwanda, which is pretty amazing. Did you have a question?
I do. In the beginning, you talked about how, as much as there's been this widespread global advocacy for family planning, there's some cultural barriers in some places. But when you look at some regions like East Africa, where there's relatively some homogeneity between countries in how they view family, sexual activity, and gender roles, the role of a woman, there is some homogeneity in how they look at those things. But what insights might you have on why advocacy in some countries has been effective? You see Kenya, the birth rate, I think between 2005 to now has dropped from 6 to 3. Yeah. Tanzania also from about 5 to 3.5. In Uganda, it's gone up from 5.9 to 6.5.
Yeah.
We're just in the same region, and I don't think it's an access issue. What do you
think? I agree with you completely, and the cultures are fairly similar. I think in Kenya especially, the government was definitely supportive of family planning, and policies changed. They made it accessible to adolescents, including unmarried adolescents, so did a lot. And Uganda, the president, who is still the president, Museveni, doesn't really think family planning is needed. And there was a joke, and I don't know if it's true, it's not really that funny, but he said, we're not going to invest any money in family planning. And then apparently he had a big farm with cows, and some of his cows disappeared. And he was angry and went out to the village to find out what had happened to his cows. And they said, well, this is a really poor village, and we think people took them to eat them because they're starving. And he said, why aren't they using contraception? Why aren't they having so many children? So, you know, it's like when it affected him personally. So, but again, that's why I think it really is an advocacy argument in getting the policymakers. And again, Uganda's right next to Rwanda, and yet look at how different it is. I remember when I went to Uganda once, and I was they were very upset. I kept saying that, well, in Rwanda, the CPR, as we call it, contraceptive prevalence rate, has gone up to 40%, and Uganda stagnated at 24% for years. And they would say, well, we don't believe that. That's not true. You know, it's like there's a lot of competition among countries, and sometimes that can work too if you can get it to translate into good policies. But it's a good point, and there still are a lot of countries in which, like I said, a woman's value can be associated with how many children she has, or it's just really a pronatalist culture. An American friend of mine got married to a man from Greece a few weeks ago, and all of the toasts at the wedding were about like, how many children you're gonna have, and preferably boy children, you know. It's like, yeah, boy, well, you know. But anyway, it's not gone. So again, what these two, the more effective methods are provider dependent. In other words, you need to have a provider. What's interesting though is with the injectable, which lasts for about 3 months, more and more countries are experimenting with something called cyanopress, which is actually, can be injected, first of all, at the community level, and can be injected by the woman herself, and does not need to be refrigerated. So there's a lot of evidence coming out that you could actually give a woman a year's supply of cyanopress and she could self-inject. And a lot of organizations are putting efforts into that, which is really interesting and exciting. And injectables are very popular, partially when women don't want to tell their husbands. Unfortunately, that's true, but.
With that program that you just mentioned, is there some concern? I mean, is there a cost associated? Because I just imagine that a poor woman would be like, oh, I have to, instead of doing it every month or however, whatever the time frame is, I've got to space it out more because I can't afford it. Is that ever a concern, or do they address that?
Well, cost is always a concern. So the countries that have been most successful, the poorer countries, actually have either free contraceptive methods or really subsidized methods, so the cost is less of a concern. And again, can justify it by saying, we know we're investing in economic growth for our country.
So they won't see that happening because they are subsidizing it or giving it for free.
There's a real tricky thing around free. Sometimes like a very small price is better. It's more effective than free,
right?
Because people associate a value with it, and that has been shown with condoms a lot. Like if you give them out for free, people are going to think like, oh, the U.S. is giving us the condoms they don't want. Whereas if you can charge a very small, affordable price, or for a bed net, it's the same thing. People will attach a value to it, and they will see some quality in it. But that's a good question too. So implant use is rising quickly and having an impact on a lot of countries, especially in sub-Saharan Africa. And again, it's long-term, but also reversible. So if you look at all these countries, a lot of them went up dramatically over a 5-year period or more in the use of implants. I just wanted to show that. I thought it was interesting. Task shifting is essential. So like I said, community health workers being able to offer family planning has had a huge impact in many countries, and now self-injection or self-use could even have a greater impact. And it'll be really interesting to continue to follow what's happening with that. And even with community health workers, or what are called here lay health workers, you really you can't just give somebody a 2-hour training and say go out. And again, if we remember that fear of side effects is one of the reasons women don't use it, you really need to have somebody who's trained in educating and communicating and do a lot of mass media or do whatever it takes to tackle those barriers to use. So we're really excited about some of the new technologies that are coming out, like cyanopress and self-injection, affordability of methods and innovative financing, and that includes what we call domestic resource mobilization, so countries themselves buying contraceptives, and then engaging youth in a whole new way. And IntraHealth has a program in West Africa that's called Youth Ambassadors for Family Planning, and they tend to be between like 18 and 24, and they, and Caitlin knows about it, she worked on it a little bit. They're advocates in the sense that we've always had a lot of peer educator programs where they go out and they teach their peers, but these young people will like storm the parliament And they will, and we've worked with them to analyze policies so that they can actually write an editorial in their local newspaper and say, this is why we don't want this. So it's kind of youth having a voice in a new way. And it's just, so, and having worked with some of these young people now for 5 years, it's really exciting for me to see like how far they themselves have grown. And many of them want to do this forever now, and just, so it's really great. Again, just a reminder, reproductive health investment can help us with all of the SDGs. And my last slide is just a reminder that it's really an investment, and we shouldn't see it just as a cost or a line item, so it's important to continue to advocate. And I have 9 minutes left, but are there any questions that you didn't get to answer during, or any reactions?
I have a question. I was wondering, do you see, you've been working a lot in Africa and you know how they're economically developing, and so do you see some kind of difference in like the perception of family planning different in socio-economic groups? Like when I was in Tanzania for a little bit, like more educated people were more prone to family planning, and even men were like, yeah, you know, I don't want to have a lot of kids. But when I was just talking to, you know, just regular, you know, just not really educated people, they were like, what is family planning? Like, I'm going to have as many kids as I want.
Yeah.
So it's like, I saw a lot of disparity between the...
It still is an issue, and if you look at wealth quintiles, you know, the wealthiest people tend to use it more. And in a lot of even poor African countries, the wealthiest people use it at the same rates that people in the US do. The one thing that's helped in some countries, and we have a program, several programs in West Africa where they're actually mostly funded by the Gates Foundation, and they intentionally, this was new, they started in urban areas. So they started with, like in Dakar, the capital of Senegal, and really focusing on urban areas where access wasn't necessarily the issue, but use was still pretty low 8 years ago. And the idea was that the urban, a lot of people who live in rural areas or are poor also aspire to a life that they don't have, so that they almost model their behavior based on what's happening in urban areas. And also showing, it used to drive me crazy that the flip charts that I saw like 20 years ago would show a poor family with 7 kids sitting in the dirt, and then next to it there would be a picture of a wealthy family watching TV with 2 kids. Well, if I were a poor family sitting in the dirt, first of all, I'd be offended. And secondly, I'd be like, oh, family planning is for rich people. It's not for people like me. So I think we've become much more sophisticated about how we talk about it, I hope, because I haven't seen those recently, but it's a really good point. And it does, cause and effect are hard, because with social economic development, people do want fewer children, and they do want, and there are more economic opportunities for women especially, but women and men.
So I'm curious about your advocacy to the U.S. government in particular with regards to the president's budget that came out that had 0 money for family planning. And I'm going to ask a question that was asked at the Reproductive Health Symposium, and would just be curious to get your thoughts. And it's, why do you think that is? Like, what do you think was the motivation of having kind of proposing the budget with a $0 for family planning? And given that, what do you think are sort of the advocacy strategies that then are most effective to put those funds in to continue the U.S. investment in family planning?
That's a great question. I won't pretend to understand his motivations, but there are obviously political motivations, and it was drastic, and it freaked us out, quite honestly. Again, still funding for maternal and child health, but basically zeroing out family planning and zeroing out our contributions to the UNFPA, which is the UN Fund for Population Assistance. I think it was almost, they wanted a shock effect and to show, and I think the Vice President also had a lot to do with it, because he was very involved in the budget negotiations. And the irony is, like more than 90% of women in the U.S. use modern contraception at some point in their life, including Catholic women. including, you know, the wives of these senators who are voting against it, or maybe the senators themselves who are voting against it. So it's like, it's so mind-boggling for somebody like me, but and then also threats to cut Planned Parenthood, where we know, even if you're against abortion, the best way of reducing abortion is making contraception widely available. There's a great study, Colorado made it free for everyone for 5 years, and abortion rates plummeted. I mean, it's like a no-brainer. What we have been told, and there are a lot of meetings in DC all the time, there's a whole community of advocates working on it, but is that, especially with the very religious members of Congress who do care about, well, they all care, I'm trying to be neutral here, but that's where we tend to use more the humanitarian argument, as well as economic growth. That we want to grab. We don't want to have to give or help. We want to help poor countries, but if we invest in certain things, we won't have to help them as much forever. So it's like how you tailor that economic argument, but also like babies are dying. You know, women are dying. This is an untenable situation, and these countries are just getting poorer and poorer. And we've been, even in very conservative offices, we've been well received, and people are willing to talk about it. And usually the staffer who's in charge of health totally gets it. You know, it's not like they're gonna not get it. So it's kind of how do we work with them, and how do we ensure that, I mean, first of all, that global health funding stays. Every study shows that the American people believe that we should invest in global health. And you've probably seen the study, and Kaiser Family Foundation does it every year, where they ask people, should we invest in a variety of things, global health, and yes. But then one of the questions is, but a lot of them say we're giving too much money. And they ask them, what do you think, how much money do you think we're giving to poor countries? And they say 25%, when the reality is less than 1% of our national budget. Whereas a lot of European countries are closer to 10%. So I think there's